Okay, doctor, I'll just start with the webinar now, and you can take a pause for 30 to 40 seconds, and then you can begin with the webinar. And doctor, if you would like to switch the slide, you can just say next, or you can just let us know. We will just we'll do it from our side.
But for my presentation, I will share it from my side because I have some remove and add some slides.
Doctor, yes, the presentations for the doctors will be from their end only. It's just the introduction slide what we are sharing currently.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Thank you for all the attendants who have joined so far for this live webinar. Welcome, everyone. Today, we are together in this session, which is run by the Young Leader Forum under supervision of Emirates Diabetes and Endocrine Society. It's going to be a live webinar, and it can be requested for the on-demand videos for the recorded as well. For today's session, it's mainly focused on the thyroid care. As you guys can see the topic for today. My name is Dr. Faryal. I'm working as a specialist endocrine and diabetes in Dubai Hospital. I'm holding a specialty certificate in endocrinology from Royal College of Physicians. I have done my residency in internal medicine and accredited by Saudi Commission of Health Sciences and Arab Board for Health Specialties. I'm also a member of Royal College of Physicians, UK. Next, please. Our today's focus will be on the thyroid care. Our first presenter is Dr. Nada Ben Haris. It's my pleasure to introduce Dr. Nada Ben Haris. She's a consultant endocrinologist in Tawam Hospital and Sheikh Tahnoon bin Mohammed Medical City, Al Ain, UAE. She's also an assistant professor of medicine in UAE University. She has completed her residency in internal medicine in UAE, followed by advanced fellowship at the University of Ottawa, Canada. In addition, she has done her clinical lipidology, research fellowship in adult endocrinology and metabolism. She leads the lipids clinic at Tamam and STMC, focusing on the cholesterol, triglycerides, disorders, diabetes, and cardiovascular risk management. She is committed to have advancing patient care, training future healthcare professionals, and contributing internationally as a recognized expert in lipidology. It's my pleasure to have you here, Dr. Nada Ben Haris. The floor is yours for the first presentation.
Thank you very much, Dr. Faryal, for this introduction. Beside my fellowship in lipid, also I did a fellowship in thyroid and thyroid cancer. So that's why also my second focus is in thyroidology and especially thyroid cancer.
Welcome, Dr. Nada.
Thank you. So to share my presentation, just a minute. Is it clear now? It's okay?
Yes, Dr. Nada, your presentation is clear. You can start.
Okay. Today I requested to speak about evaluation of thyroid nodules. So I want to talk about the update 88 thyroid guidelines, American thyroid guidelines, and how we do it in practical approach. So nothing to disclose. So my objective today to highlight the key limitation of 2015 ATA guidelines of the thyroid nodules and to introduce the rationale behind the change of which happened from 2015 to 2024 in the ATA guidelines, review major change proposed in 2024 draft guidelines, including the ultrasounds and the recommendation, and then we can go quickly over comparison and one case like review. So the main limitation in 2015 American thyroid guidelines that there is many nodules has been non-classifiables. So as you say here in the figures, non-classifiable nodule in 2015 guidelines is a huge number. 44% of those are being mixed solid cystic suspicious features, so it's not been classified, or it's either hyperisoechoic solid with some suspicious features in 27%, or as you can see here, like any nodules with not clear echogenicity. Also, what was hard to be classified in 2015, so it's been unclassifiables. So this is really a big numbers, and that's why the change happened for this in new guidelines. So when there's, they want to know how much of those nodules has been non-classifiables. So pooled analysis for this unclassifiable nodule, it showed that it's around or near to 10% of all those nodules has been non-classifiable in 2015 guidelines. So, and then what the risk of malignancy on those all non-classifiable nodule? So again, another pooled analysis showed that it's around 20% of those non-classifiable nodule turn to be malignant. So this is really a big numbers, and that's why the change which happened in this new guidelines. As you can see here in the draft of the guidelines, it shows that the major important things that all nodules should be classified. So classification for all nodule with calcifications, so should be classified, and that's which happened into 2024 guideline. And then classification for all partial cystic nodule, and then estimation of the risk of malignancy without gap, and that's with all update to current literatures. And you can see here from the draft, when we compare between 2015 and 2024 risk of malignancy, there is a huge like limitation in the intermediate when it's in by 20%, and then we have a high risk group starting with 70% risk of malignancy. So there is a big gap here. So the important with all emerging literatures is to close this gap, which we can see it very nicely in 2024 guidelines, when the gap has been closed with 50% in the intermediate risk in 2024, and then to start like with the high risk above 50%. So this is one of the major change, closing this gap between 2015 and 2024, and that's based on all reviewing the new literatures which it is arised. In the main things in 88 2024 thyroid nodule guidelines, that we can see the classical suspicious features are only applied to solid nodules. So there is no more any suspicious features is applied to cystic nodules. For example, if you have, we can see like cystic nodules, and then you start to add suspicious feature on it, that the main cause for false positive ultrasound results. So that's why they omitted that and they remove it from the new guidelines. So all nodule need to be solid nodule, and then you can add suspicious features on top of it. So allowing for limiting certain combination, as I said, such as spongiform, microcystic, and then add echogenic foci on top of it. It's not anymore allowed in the new guidelines. So still maintain photo album, which we know it. That is still, but it will be more in color. and abnormal cervical lymph nodes and clear extrathyroidal extension are not anymore considered to be in the thyroid nodule guidelines. It's because it's considered a high suspicious and removed from the algorithm. So the algorithm is a stepwise approach, and today I will take you over it. And we will start when we seeing any thyroid nodule. First of all, the question is what the consistency. So we need to know consistency, and then after that we think about echogenicity of this nodule, and then we will start to add those suspicious features on top of it. So then we can guide to read this nodule. So here is the draft of 2024 ultrasound features. So still it is pattern recognitions features. So as we can see, as I said, number one is what the compositions of this thyroid nodule. So is it cystic? And if it is cystic, need to be more than 10% cystic, and or it is solid, which need to be more than 90% solid. So we will call it solid nodule, or cannot assess the compositions. Then, when we know the compositions, the number two, we need to think about echogenicity. So is it hypoechoic? Is it markedly hypoechoic? Or is it isohyperechoic? So number three is adding a suspicious features. So suspicious features, we can say it is either to be intermediate suspicious when there is no any additional suspicious features. So marked hypoechoic by itself, it is something suspicious. So without any adding features, suspicious features, it's in the intermediate group. If you have one or more of those suspicious features, so it is considered to be high suspicious feature. So what the suspicious features? Again, it's need to be only in solid. And then I put it down in the slide. Either it's panictate echogenic foci, irregular margins, irregular halo, macro calcification taller than white. So this is the main suspicious feature when we searching for, when you are looking for an ultrasound in the clinic. So for hypoechoic, two or more, it is high suspicious, or one, it's intermediate. And if there is no any suspicious features, one which I mentioned, the five features, so it's considered low suspicious. And for isohyperechoic, if it is one or more, it's intermediate, no any suspicious, so that low risk. And then we will go for cystic. As we know, the main cystic, it's either to be spongiform, pure cystic benign, or partial cystic. So for partial cystic, we know all of us, example of its classical cystic PTC appearance, which it is high suspicious, partial cystic with PTC appearance. So all the other type of partial cystic nodule, it's low suspicious. And then in spongiforms, either it is be low suspicious, or it's be very low suspicious when there is no any suspicious features, and we cannot assess the compositions. We will talk about here irregular peripheral calcification with protruding tissue. So this is high suspicious, or irregular peripheral calcification. It is considered to be intermediate suspicious. And then when it is smooth, then peripheral calcification, again, that is low suspicious features. So if I will go in more in details, maybe a solid is one of the most common nodule, which we see it in the clinic and the ultrasound. So when we think about this is a solid nodule, as we can see here in the figures. So highly suspicious, again, we think about if it is one or more suspicious features, and intermediate suspicious when there is no any suspicious features, or it's be not markedly hypo and one suspicious feature, or in isohyperechoic, those but with one or more suspicious feature, as you can see here in the figure. So this is considered intermediate group. You will see later on how knowing those high, intermediate, low suspicious will affect us when we choose do we need to go for biopsy or no. low suspicion when there is hypo, iso, or hyperechoic, and there is no any features which like here you can see it very clear. There is no any suspicious features in this ultrasound, so it's very low. It's hypoechoic, but there is no any calcifications, nothing there. In partial cystic nodule, again, it's need to be more than 10% and the nodule to be cystic portion on it. And then high suspicious, we need to think when it is there is solid component, a component with acute angle protruded, so plus intrasolid panictate echogenicity foci. So this is macrocalcification, and we know what's example of it, PTC, or it's low suspicions when there's not classified as high suspicious features, as the figures here. Spongiforms, we see it a lot, and again, it's low suspicious to start with, macrocalcification or irregular outer nodule. I try to put many figures so make it clear for everyone, and then very low suspicions when there is solid component or are all spongiform microcystic nodule as we see here. And again, we cannot say that this is a panictate because we agree from beginning there is no panictate seen in cystic. So consistency cannot be assessed due to dense peripheral calcification. You will see in the new guidelines, it will come with 3 category, either high suspicious, as you see in the picture, peripheral calcification with protruding soft tissue, or intermediate irregular peripheral calcification, no protruding soft tissue, or low suspicion when there is thin irregular peripheral calcifications, no protruding soft tissue. So here is the ATA 2015, how it was looked, if you remember the atlas and how it was there. So what we have here, benign and very low, low, and then we have high, and then the new added in the guidelines, we can see here that there is irregular margin has been added as a high risk features. Then we have in the low hyporegular margins and regular calcification with no protrusions has been added. And the spongiform, we can see also been added. And this is entire a new row of the intermediate group. This is a new, will be added in 2024 ATA guidelines. You can see here started with marked hypo with no suspicious features, and hypo with one suspicious features, and then hypo with one or more. And this is more pictures. And then isoechoic with one and irregular calcifications with no protrusions. Again, it's added as an intermediate group. So I tried to make it simple and just to show that why is the change happen, how we close the gap, and in the new guidelines, and then what the added and what the expected that you will see in the new guidelines. So also in the new guidelines, it will be colorful. So there's some things good. So we'll start with the case. Here a case of a 63-year-old female with 1.4 centimeter thyroid nodules. So she came to the clinic asking about, and this is the ultrasound. So how you will evaluate this lady with 1.4 centimeter thyroid nodules. So anyone remember like what we said? We start with what? We start with consistency. So how you think this consistency to start with? Is it, we can see again, is it solid? Is it cystic? Or you cannot assess? As you can see here, it's we can see that it is a solid, and then we will go for echogenicity. Did you think it's hypoechoic, hyperechoic, or isoechoic, or markedly hypoechoic? So we again compare it with the strap muscles. So you can see that it is hypoechoic. Okay, and then again, when we will see, you will start number 3 to add the suspicious features. So you can see that we have some calcifications. So we can say that it is having, yes, there is macrocalcifications and it's have some features. So it's in the intermediate group. So how you think about patients with solid hypoechoic with +1 or more? Even I can see here that some echogenicity penictates and the margins, if you can see here, like a little bit regular. So do you think it's fallen within intermediate suspicious? So then you think about what the risk of malignancy. Risk of malignancy in the intermediate suspicious group, it's around 20 to 50%. Do you want to biopsy a patient with 20 to 50% risk of malignancy? So again, this is something answered in the draft guidelines, which you will see in 2024 guidelines. This is a size threshold for FNA. So for intermediate case like our patients, range or risk of malignancy between 21 to 50%. So the threshold range for fine needle aspiration is from 1 to 2 centimeter. So yes, this patient is fallen within the cut range of the biopsy. So maybe, yes, you are right if you want to go and biopsy this nodule. So consider FNA if it is less than 1 centimeter. Again, if there is abnormal lymph node, if there is extrathyroidal extension, if there is posterior location, which we will worried about, or there is personal risk factors or the personal preference if they want to go. So, and another factor which influence your decisions making for FNA, and again, it's within the recommended size threshold, age. So maybe you will favor smaller size cutoff for biopsy if they are younger. And maybe you will say, okay, she's old, so maybe I will biopsy it if it is 2, because the biopsy cut range between 1 to 2. So you will favor going to the 2 size cutoff. So that's again is right. A personal risk factor for thyroid cancer, like childhood, extra beam radiations, or genetic syndrome. So if that presents in the, you will favor smaller size cutoff. And if it is absence, maybe you will go for favoring a larger size cutoff. A comorbidity, if it's absence, again, favor smaller size cutoff. And if it's present, no, you will go for larger size cutoff because they already have a lot of comorbid and you're worried about these patients. If there is abnormal in the imaging, so yes, we will go for smaller size cutoff. That makes sense. And if the patient have any symptoms attributed to this, and usually patient came complaining already of dysphagia or voice change, so you will go for it even if it is with a smaller cutoff. So still it is something which you need to discuss this with your patients. Location, for sure, isthmus posterior location, usually a little bit higher risk, and we are worried about those locations. So maybe you will favor doing a biopsy if it is even in a smaller cutoff. So this is the things which usually we discuss it with the patient in the clinic, and remain like patient voice is high, even in it's higher in 2024, and patient preference usually playing the major decision making. So if the patient said I cannot sleep on it and I worried about it, so that's again some things you need to consider and go ahead for biopsy. So this patient, which is 63 years old female with 1.4 centimeter thyroid nodule, so ATA sonographic patterns, we said it's intermediate suspicious, so risk of malignancy 20 to 50%. So think about threshold range for FNA. We said it's 1 to 2. We already discussed about what the points making me favor the maybe smaller cutoff or larger cutoff. So after thinking and taking all considerations and discussion and taking the patient preference, so what we need to do next, she decide to go for FNA. So go ahead and, okay, do the biopsy. So then came back benign. So what you will do next? Here you are stuck. So did I need, the patient usually ask, okay, it's benign. Did I need to repeat the biopsy? Or did I need, when I will do the next ultrasound? When I do, again, this has been addressed in 2024 guidelines. Here, which I need to show in this study, that usually when it is benign, and I don't worry about transformation, that this benign cytology will transform to be malignancy. But which I worried about is usually how many percents maybe I'm missing the diagnosis in this patient. So maybe I diagnose the wrong spot, where I biopsy the wrong spot, which I maybe miss the diagnosis of cancer. From this study, it should make us rebreathe, because usually the higher risk of malignancy, for example, if you see here with 5 features of risk, so the missings of the malignancy can be higher, which around 22%. But the patient to start with, and they are low risk for cancer to start with, there is no feature, or they have only 1 features, or they have 2 features, you can see here that the risk that you miss the diagnosis, it's very low. So if patient have only 1 suspicious features or 2 suspicious features, as you can see here, it's very low rate that you miss the diagnosis of cancer in this patient, versus the patient who start with to be having 5 features. So those which have 22% may be risk that you miss the diagnosis. So based on that, maybe what we will decide for this patient to do next, the ATA ultrasounds patterns at FNA in our patient, who she is an intermediate case, she's fallen in the 20 to 50% risk of malignancy. The ultrasounds follow up after initial benign cytology, 18 months to 3 years. This is the ultrasounds follow up. Usually in the clinic, I disclose very clear with the patient the risk of malignancy. They need to hear it usually, and they need to know that there is a still risk. Okay, I told you it's benign, but there is a risk still 20 to 50% of malignancy. But again, the risk is low. So in consider, so we're doing repeat ultrasounds in 18 to 3 years. Repeat FNA only if there is change to more suspicious ultrasounds pattern. At that time, yes, you need to repeat the FNA for this patient. And this is here showing the strength of the recommendations and the quality of evidence. So this is the case which I shared from the clinic, and then follow up of nodule with benign cytology. If a nodule has undergone repeat ultrasound guided FNA with a second benign cytology, for example, 3 years passed and you decide to repeat the ultrasound biopsy for this patient. So ultrasound surveillance is no longer indicated to continue monitoring for malignancy. You did first biopsy and you did second biopsy, and it is already benign. So there is no longer any indication to repeat doing an ultrasound. And this is a very strong recommendation with moderate quality of evidence. Then,
Dr. Ananda, you have 5 minutes left for your
okay,
presentation.
this is my last
Thank
slide.
you.
If
Sure.
another with benign cytology is stable in size and sonographic patterns at 5 years, the utility of continuous sonographic surveillance for missed malignancy is less likely of very low value. Okay, so further surveillance ultrasounds are not recommended unless patient develop a new symptoms. So this is my last slide, and thank you very much, and I'm welcome to receive any questions.
Thank you, Dr. Nada, for such a wonderful presentation and a review and a very nice comparison between 2015 and the most recent ATA guidelines. It's of utmost importance for all endocrinologists. Thank you so much for the beautiful presentation. For all the participants, we will be receiving questions in the QA session at the end. We will proceed with our next presenter, Dr. Budur Al-Imadi. She is going to discuss a very challenging topic in endocrinology, amidron-induced thyroid dysfunction. Let's start with her introduction. She is a consultant endocrinologist in Dubai Hospital, UAE. She has completed her MBBS from Faculty of Medicine and Health Sciences from UAE University. She has completed her internal medicine residency and as well as fellowship degree in endocrinology from King Fahd Hospital, Saudi Arabia. She has, after that, completed her specialty certificate examination in endocrinology from Royal College of Physicians, followed by obtaining an endocrine certificate in neck ultrasound. She very nice consultant to work with. I am pleasured to work under her supervision in Dubai Hospital. She efficiently works actively as a tutor during her training program in King Faisal Hospital, KSA. She has been awarded multiple times as endocrine fellow, a couple of times the best endocrine fellow in their facility. Through her career, she has been involved in medical education for medical students as well as under trainee residents and fellows. The floor is yours, Dr. Badur. Welcome on board.
Thank you very much, Dr. Surya, for this nice introduction. It's a pleasure always to work with you. Just minor modification. I did my training. It was in King Faisal Specialist Hospital, not King Fahad.
I'm sorry for that.
Okay, so I'll be sharing the presentation. Yeah, it's on. Okay. Okay, so my subject today is about management of amiodarone associated with thyroid dysfunction. We'll be reviewing the guideline and the clinical updates. So this presentation is aimed at reviewing the current evidence and providing answers to questions that is very frequently encountered in the clinical practice. I have no disclosures, and these are my objectives for tonight. I'll be describing some epidemiology, pharmacokinetics of amiodarone. I'll try to list the different how to differentiate between type 1 and type 2 amiodarone-induced thyrotoxicosis, then outline what's the evidence-based diagnostic approach for above, formulate a comprehensive individualized management, and review the recent literature and identify the gaps in the current practice. These are some of the resources that I have used to prepare. So,
sorry to interrupt, Dr. Budur. Your screen is not visible yet.
I shared, yeah.
Yes, your presentation is not visible yet.
Okay, how about now?
Not yet.
I'm clicking on share screen.
Mm-hmm.
Yeah, okay. I think now, yeah, share. How about now?
Yes, we can see the screen now. Thank you, Dr. Budur.
So some basics about amiodarone. It's a medicine that's iodine rich, and almost 1/3 of its weight is loaded with iodine. And this drug can cause changes in thyroid function test. Many times these changes has no clinical implication, and only less than 30% of the time where it can cause a true thyroid disease. Now, the most important metabolite of amiodarone is the DEA. It results from dealkylation of the amiodarone in the liver, and the dealkylated metabolite has a potent antiarrhythmic effect. Both the medicine and the metabolite are extensively lipophilic, and that's why it diffuses through many tissues of the body, and that explains the longer half-life that's required for the elimination. Now, more than 70% of patients, when they are treated with amiodarone with the standard dose 200 or more than this, most of the time they will remain euthyroid, with only 20 to 30% who will go into hypothyroid or thyrotoxicosis. There are some factors suggested that may increase the risk of thyroid dysfunction in population like older age, female when it comes to hypothyroid, thyrotoxicosis when it comes to male, some heart failure, and some suggested higher doses of amiodarone. Now, the TFT changes that can happen with amiodarone therapy, and I think it's important to know about it. To know about it is important because it does not require treatment once you recognize it. So, because of the acute phase is within the first 3 months of the use of the amiodarone, and the chronic when it goes beyond the 3 months. So, the first phase, what happens with the wolf check-off effect, because of the high iodine load from the amiodarone, it blocks further iodine intake into the thyroid gland and leads to a transient phase of hypothyroidism or a transient rise in the rise in the TSH. On the other hand, the amiodarone has the peripheral mechanism of action that it blocks the deiodinase enzyme that converts the T4, it downgraded to T3. So it blocks this enzyme. This leads to a relatively higher T4 and a lower T4. This relatively high T4 and lower T3, it creates the euthyroid status while the patient amiodarone, and that's why it does not require treatment. In the chronic effect, it's almost similar. The only difference that TSH goes back to normal. The importance of when dealing with amiodarone-induced thyrotoxicosis, because patients with amiodarone have a diseased heart. So the thyrotoxicosis in this setup will cause significant worsening of the underlying heart disease. Now, these triple combo that I've been mentioning now, I keep reinforcing my presentations, elderly, left ejection fraction less than 45%, and the development of amiodarone-induced thyrotoxicosis. These triple combo is a lethal combo. Why I'm saying lethal? Because the mortality rate, if left untreated, almost 50%. That's why it requires a prompt treatment for the thyrotoxicosis. Now, the major challenges when treating thyrotoxicosis, first, the difficulty in differentiating between type 1 and type 2. And in those patients, thyrotoxicosis in the setup of amiodarone lack the prompt response to medical therapy and often leads the physician, resulting in uncertainties about what type he's dealing and what's the best initial therapeutic approach. And the third, there's always a diseased heart that can deteriorate with the thyrotoxicosis. So we have here a case, 68-year-old male who presented with dyspnea and weight loss. He had an underlying ischemic cardiomyopathy, ejection fraction 35, atrial fibrillation on amiodarone 400 mg. So in examination, he was clearly tachycardic. He had mild tremor, no goiter, no neck tenderness, no signs of decompensation, and biochemically very clear thyrotoxic picture with a high inflammatory markers. Further workup, ultrasound showed normal thyroid, no nodules. Doppler showed absent vascularity. Radioiodine uptake was not down due to the recent iodine load from the amiodarone. So when it comes to differential diagnosis, I think we all agree that top of the list would be amiodarone-induced thyrotoxicosis. Graves, probably unlikely given the absence of orbitopathy, thyroiditis, no neck pain, toxic MNG, unlikely as the ultrasound has no nodules, factitious, there is nothing to support in the history. So when we encountered this case, the questions that came in clinical practice, that which type we are dealing now, should we advise the cardiology to stop the amiodarone, and what's the best treatment approach initially? Should we start with thiamide, steroids, or both together? And what factors influence the prognosis, and how frequent should we monitor? So to address these questions, we went back to the literature. Now, the general statement or the standard statement is that type 1 thyrotoxicosis usually develops in someone who had previously ill or thyroid disease, and type 2 usually in a healthy thyroid disease, and a mixed, it means a combination of above. However, the presence of the nodules do not rule out that this could be type 2 amiodarone-induced thyrotoxicosis, which nowadays is becoming the most common type. If we looked at the epidemiology of the amiodarone-induced thyrotoxicosis, it more commonly occurs in men with a ratio 3:1 as compared to hypo, and the course is less predictable in terms that it can occur at any time during the course of the therapy, or even 3 years after discontinuation of the amiodarone. And usually, when it's after discontinuation of the amiodarone, it's very likely going to be type 2. Now, do the clinical presentation with thyrotoxicosis in someone amiodarone differ than not in amiodarone? Yes, it does, because all the time those patients are going to be in beta blocking activities that will minimize the manifestation of the adrenergic symptoms, and that's why the manifestation could be only redevelopment of an atrial arrhythmia that has been controlled in the past, or exacerbation of underlying ischemic heart disease or heart failure, and explained weight loss, restlessness, or a low-grade fever. And one important point that we have to be cautious about, that if you have someone in warfarin and had for a very long time therapeutic INR, and suddenly you're having a supratherapeutic INR, suspect, have a low threshold of having thyrotoxicosis. And the reason for that thyrotoxicosis enhances the metabolism of the vitamin D dependent factors. And this leads to deplete these factors and potentiate the effect of the warfarin. So what are the diagnostic tests that should be taken into place to differentiate between type 1 and type 2? Now, presence of TRAP suggests Graves and could suggest an underlying type 1. Now, we have to know that most of the labs who do the TRAP assay is a TBI. TBI is a thyrotropin binding inhibitory. So it does not differentiate whether you are dealing with a stimulatory immunoglobulin that makes sense that it's more in type 1 or blocking of the neutrophil that is in type 2. And usually thyroid antibodies is absent in type 2, but again, there are a small percentage of people who would be having this autoimmune thyroid antibodies in type 2. Another clue, when approaching, by the way, for the diagnostic test, you have to maximize the number of tests. You have to exhaust the patient from utilizing the resources to categorize the patient whether you're dealing with type 1 or type 2. Now, if we look to the ratio, T4 to T3 generally is the ratio is high in destructive thyroiditis, but you have to be cautious in interpreting this ratio because already in someone in amiodarone, his baseline of FT4 is high, and that's because of the mechanism of deiodinase that blocks the conversion of T4 to T3. So you cannot apply this criteria 100%, but you go and collect as much as possible diagnostic tests to support you, whether to assist you, whether you're dealing with type 1 or type 2. Now, when we're coming into the nuclear imaging testing, we have 3 nuclear imaging for the thyroid. One is the radioactive iodine, the pertishtinate, and the system AB scan. If we're talking about someone living in iodine deficient areas, when the uptake is 0, it's type 2. When there's some uptake, it's type 1. However, in replete areas, when it comes low, would not differentiate between either type 1 or 2, but when there's some detectable uptake, would favor type 1. Now, what about the role of ultrasound? It has a low diagnostic yield apart from assessing the nodularity. And again, the presence of nodularity does not exclude that patient could be having type 2 destructive thyroiditis. One very useful tool when used by a skilled radiographer is the Doppler, where it will be a hypervascular in type 1 and absent vascularity in type 2. Now let's move to the next nuclear testing is the system AB. So this system AB, just to let you know, it has not been adopted by the guidelines, but there's so many promising reports being released about the system AB. You can use it in the context that patient is still on the amiodarone. So in type 1, there is increased uptake, and type 2, there is reduced uptake. It differs from the radioactive iodine because here it does not depend on the iodine to differentiate between the two scenarios, because it depends on the mitochondrial density. In type 1, there is dense mitochondrial. In type 2, there is minimal mitochondrial activity. Why it's not adopted by the guideline? Because most of the studies that have worked on system AB, they have been all like small cohort studies, single center studies. Guideline committees usually adopt this as a diagnostic tool or as a first line when it has been done in multiple centers, getting consistent results and high-powered sample size. But the published report is really promising. Another diagnostic tool that you can use is the interleukin-6. It's a marker of inflammatory or destructive tissue. If your lab have it, go ahead and use it. So in type 1, there might be some elevation, but in type 2, with the destructive thyroiditis, there is a massive elevation in the interleukin-6. Now, generally, when we're having this quadruple combination, absent goiter, reduced radioiodine, absent vascularity, absent receptors, you're very likely dealing with type 2 destructive thyroiditis. So now we go back to our case. He had ejection fraction 35, no past history of thyroid disease, no nodules, absent vascularity, high inflammatory markers. So it favors the type 2. He was started on prednisone 15 mg. However, his cardiac status deteriorated and he went into frank pulmonary edema, and FT4 is still in 40. So at this stage, we said, should we go for urgent thyroidectomy despite having a high FT4, or should we optimize the patient before surgery, or it's time to add on to the prednisone, to the thiamide, or stabilize the cardiovascular status, maintain the hemodynamics, then send the patient for definitive therapy. Again, to address this question, we have to go back to the literature. So this is agreed. It is not what I'm suggesting. That has been in so many papers that we are having a deteriorating heart, salvage thyroidectomy should be there. To because in a deteriorating heart in the context of thyrotoxicosis, there is a very high chance of mortality. Salvage thyroidectomy always is not a solo decision. It's done under the MDT setup where there is cardiologist, endocrinologist, high volume surgeons, and expert anesthetist. So salvage thyroidectomy, there is severe thyrotoxicosis, deteriorating cardiac function. Usually patients have an ejection fraction 45 or less. This is the lethal combination, or patient will have an underlying severe heart disease. Here you want prompt restoration of the thyrotoxicosis, and this is done by thyroidectomy. And with salvage thyroidectomy, the cardiac function improves in a very short time. This approach has been adopted by the European Thyroid Association. Now, what about the plasmapheresis? Plasmapheresis, the mechanism, they remove the thyroid hormone, the free and the one that is bound to the plasma proteins. However, this plasmapheresis procedure is short-lived procedure, so it will only be effective in 24 to 48 hours. So you may consider it when you're having life-threatening thyrotoxicosis like thyroid storm and the setup of severe cardiac compromise, and you want something as a bridge to an urgent thyroidectomy when your medications are not working or there's a contraindication. Not a usual practice because it's a procedure, it's an invasive procedure, no large RCTs, and most of the time patient will be stabilized on medical therapy. The other question that we need to address when the case was referred on the cardiology, whether should we advise to continue amiodarone or not. So no consensus or sufficient evidence to go with this, so that's why the decision is individualized. But generally speaking, in destructive thyroiditis, the disease is self-limited. So probably you would not advise for amiodarone withdrawal. However, in type 1, where there is an underlying thyroid autonomy, and there is already on board amiodarone that will keep feeding the gland with iodine, so probably here you would advise or suggest, suggest amiodarone withdrawal. However, the cardiologist should assess how much this medicine is essential for the heart or can discontinue the medications. Okay, now when it comes to the management of amiodarone-induced thyrotoxicosis in type 1 as compared to other in the management of in the setup in the context outside the amiodarone, the dose here is very high, 40 to 60, and usually to require a longer duration of period for the management, and that's because the thyromites have to combat the thyroid gland that is loaded hugely with the iodine. So in few weeks, if there is no response, potassium perchlorate can be added. This potassium perchlorate is only adopted by the European Thyroid Association, not by the American, and should not exceed more than 4 to 6 weeks. And the reason that though rare, it has a very serious side effects. One is aplastic anemia, second is nephrotic syndrome. And always with the type 1, because there is autonomy, you want a definitive treatment to allow the cardiologist to reintroduce the amiodarone or continue the amiodarone safely. So it's either by ablation or total thyroidectomy. If by ablation, usually it requires a duration of 6 to 12 months of this cessation of the amiodarone, and you have to confirm there's no more iodine contamination by measuring the iodine in the urine and making sure there is adequate uptake by the radio iodine. And this is the method or the recommendation that is adopted by the European Thyroid Association. When it comes to type 2, again, you can use 30 to 40 milligram prednisone or sometimes weight-based if it was severe. Usually in a month time, you have to use the full dose until patient becomes clearly clinically and biochemically euthyroid, and then over the next 2 to 3 months you start taper. If it rebounds, you go back to the dose that you step back to the dose that control the thyrotoxicosis, and then you have to slower your tapering. How to monitor? In this case, usually in the first months weekly, probably TFT, and then later twice twice monthly by monitoring TFT and inflammatory markers. So if it was amiodarone-induced thyrotoxicosis, in moderate to severe, that's the recommendation to treat with steroid. But if you're dealing with a milder form or subclinical, it is clinician judgment, and you have to take into account the severity of underlying condition. Are you dealing with severe cardiac condition, or are you dealing with a subtle or a mild abnormality? Now, the mixed form or the indefinite forms is when you cannot differentiate between both. And please, when you say mixed or indefinite, it means, when you're saying mixed, it means you have exhausted the resources, yet you have not yet reached, not from the beginning labeling the patient as mixed or indefinitive, and you did not put much effort in trying to illustrate whether you're dealing with type 1 or type 2. Now, how to deal when you are really stuck with a mixed or indefinite form? The American adopt the combination treatment from the beginning, thiamide with steroids. The European, they say you start with thiamide, whether you combine or you add on later after 4 weeks. It's up to the physician to decide. There are some after the guidelines. There have been also some more novel concepts that have came into the literature after the guidelines. Some of them I've already mentioned in the previous slide. Now, again, they have just re-emphasized that the presence of nodules does not exclude thyroid type 2 destructive thyroiditis. This is just summary of what I have all said in my previous slides. I think we have spoke about the TFT concentrations. Again, the presence of TFT, thyroid Hashimoto antibodies, does not rule out the destructive thyroiditis, but it may tell you that patient following the glucocorticoid course therapy might develop hypothyroidism. The functional assay we've spoken about. Let's go to this incidental finding of the unenhanced CT. This was a report in a patient, very nice finding, not yet again adopted in the guidelines. So they called it the white thyroid. That this patient had was an amiodarone, and he went through phases with unenhanced CT. Unenhanced, I mean without contrast. The thyroid looked like as the patient has received contrast. So when he was on amiodarone, there was little density of the thyroid has been increased. And then when he reached the thyrotoxicosis peak, the density increased and became looked like a white thyroid. And then when the thyrotoxicosis settled, it went back to baseline. That's why they called it the white thyroid, resembling the thyroid image with the contrast. Yet this procedure to me remains not very clear. It was just incidental finding in some reports and requires a large population before taking it into account. Okay, the system maybe, as I told you, not yet adopted in the guidelines because of the small cohort studies yet, though reports are very promising. I was very much interested in digging further in the literature about the system maybe. The result is really amazing. I think if someone is having in their hospital setup, I would suggest to using it. We'll go. There is one very nice article, this one published in 2020. They published an outcome of 5 patients, very interesting, where they have labeled them as one type of thyrotoxicosis, but when system EB took place, it shifted the management and resulted in a good response. For example, one of the patients who had the TSI antibodies, the stimulating antibodies were high, and he was labeled as type 1, started thiamide. So they incorporated the system EB when they have seen patients did not respond to the therapy that they have thought this is the type. So in this patient, he had TSI positive. They started thiamide. It did not respond. They went to system EB. It favored type 2 because there was no uptake, and they shifted to steroid. It showed a prompt response. Another study, another one of these patients had absent vascularity, so they thought they are dealing with type 2. They started thiamide. It did not respond. They incorporated the system EB scan. It showed increased uptake, so they shifted the it showed increase, so it shifted from the steroid to the thiamide, and it showed prompt response. Another patient, very interesting and funny at the same time, where the patient was on methimazole, did not respond. Again, they sent the patient for the cysteine. It showed type 1, though the patient's thiamide did not respond. So what they did in this case, that they have shifted the...
Sorry to interrupt you. You have 5 minutes kindly to summarize the presentation.
Yeah, I'm having very few slides left, okay? So they shifted to PTU and it responded to treatment. So this the discussion about these findings. Now, the novel concept that also emerged in amiodarone-induced thyrotoxicosis, that now they are not only looking at the control of thyrotoxicosis, no, they are looking at the heart and the development of cardiovascular mortality. So in this study, clearly May said when amiodarone-induced thyrotoxicosis in the context of low ejection fraction had a higher MACE compared to a lower. And here also they looked at, they looked at patients when they receive lower doses than that has been recommended by the guidelines. So when you're giving lower doses for patients with amiodarone, it's equivalent to giving nothing. Giving lower, because you're not combating the gland that is rich with iodine. So nothing in terms of control of thyrotoxicosis, and nothing in terms, it will not prevent the development of cardiovascular complications. This is this has been retrieved from many studies, and that's incorporated into this study. Another thing they have found that the thiamides, or in general the medications in the context of amiodarone-induced thyrotoxicosis, have a higher adverse event when outside the context of the amiodarone. Now, I'll just go back to the timing. This is my last slide. The timing of the thyroidectomy. So here, our patient required cell-batch thyroidectomy. The question was whether to go at thyrotoxic state or make the patient euthyroid. So these two studies illustrated that when you're having a high volume surgeon and sending the patient thyrotoxic state, resulted in survival advantage. Do I have this one? Okay, so this study was illustrated this finding very well. These are the 4 groups that they compared, and they have found, compared to group 1, comparing group 1 to group 3. Group 1 was thyrotoxic, reduced ejection fraction. Group 3 was euthyroid, reduced ejection fraction. So group 1 went to surgery at time they are thyrotoxic. Group 3 went to surgery at time they are euthyroid, and the survival was better in the thyrotoxic group. This has been in different studies, but this is the one I liked the way they run the study. And this tells you the thyrotoxic had a survival advantage because here the patient had a reduced exposure time to thyrotoxicosis as compared to the patient who went to total thyroidectomy when he reached euthyroid state. The heart has been bombarded for a long time with the thyrotoxic phase until they achieved euthyroid and went to the surgery. So the message that, contrary to the previous thought that someone thyrotoxic maintain hemodynamics, then send the patient therapy severely thyrotoxic, failing heart, then that's to send the patient, minimize the duration of the exposure of the heart to the toxic effect of the thyrotoxicosis. That's my last slide. So if I want to emphasize anything in this, that you have to maximize your efforts when working up amiodarone-induced thyrotoxicosis. You don't want a combination therapy because the side effects in the context of amiodarone is more appreciated. You have to do and utilize and exhaust resources to reach you are dealing with type 1 and or type 2. System EB scan has a promising effect. Patient, the combination, low ejection fraction, and elderly and amiodarone-induced thyrotoxicosis is a lethal complication. Go for euthyroid should be promptly restored. And when it's a salvage thyroidectomy in a failing heart, patient would have a better survival advantage when going in thyrotoxic phase instead of waiting for a long time until achieving euthyroid to go for thyroidectomy. And the focus in the literature change from just only controlling thyrotoxicosis to focus on how to optimize the cardiovascular outcomes. Yeah, so this was my last slide.
Thank you, Dr. Badul. Thank you so much for the excellent presentation. It was a very challenging topic and always challenging in terms of diagnosis and treatment as well. We are on the way to proceed with our next presentation with Dr. Hissa. She is endocrinology consultant in Sheikh Khalifa Hospital. She's specialized in endocrinology and diabetes, as well as specialized in neuroendocrine tumors. She is thyroid cancer lead at Sheikh Khalifa Medical City. She is going to shed light on introduction for neuroendocrine tumors, as well as the risk of medullary thyroid cancer in the patients using GLP-1 agonist therapy. You're welcome, Dr. Hissa. The floor is yours, please.
I thank you, Dr. Faryad, for this introduction. And it's my pleasure to be today with you to discuss this topic.
Welcome, Dr. Hissa.
Can you see my slides?
We can see your slides now, Dr. Hissa.
Yeah.
Thank you for sharing.
I think it just needs to be in the presenting me. Yep. Okay. So actually, after those two interesting topics, I think this is also a heavy topic to discuss today, and it's one of the hot topics now regarding the GLP-1 agonist and medullary thyroid cancer and the relation to neuroendocrine tumor. So in my presentation today, I will be giving a small introduction about neuroendocrine tumors. I will be talking about GLP-1 agonist mechanism of action, and we will discuss the link between GLP-1 agonist and thyroid cancer. We'll have some literature review and recommendation regarding the GLP-1 agonist and thyroid cancer. And also, we will see if there is any protective effect of GLP-1 agonist with other type of cancer. So what is neuroendocrine tumor? It's really important to know about this neoplasm because it's a very rare, but it's increasing recently, and it's
Dr. Hissa, we cannot hear you.
Can you hear me now?
Yes, now it's fine. Thank you.
So it's as we said, it has the property of both nerve cell and hormone producing endocrine cell. It's a rare, slow growing tumor. It's present around 0.5% of all malignancies, so it's very rare. They can occur most frequently in tissue derived from embryonic duct. They can arise throughout the body, but most commonly found in the gastrointestinal tract. Neuroendocrine tumor, it depends on the location. It can be most commonly, as you said, in the gastrointestinal tract, in the small intestine, and appendix or rectum. It can be present in the pancreas in terms of insulinoma or egloquinoma. Also, it can present in the lung and the bronchus. It can present in the thyroid as medullary thyroid cancer in the adrenal gland as pheochromocytoma and paraganglioma. And our focus today will be about medullary thyroid cancer. What's the clinical feature of neuroendocrine tumor? It depends on the location and the type of the hormone that will be secreted. Carcinoid syndrome is one of the common presentation. It's not specific, and it's happened because of serotonin secreting tumor. And as you know, it can present with the flushing, diarrhea, and wheezing. Insulinoma, it will be present mostly with hypoglycemia. Gastrinoma will be presented at peptic ulcer and diarrhea. Viboma, it's usually a triad of watery diarrhea, hypokalemia, and chlorhydria. Gluconoma, which is very important to actually to link the diabetes with necrolytic migratory erythema, which is dermatological manifestation. Classification of neuroendocrine tumor first depends first on the functionality. We either have functional neuroendocrine tumor, and then we say it's functional, it means it secretes hormone causing clinical syndrome, like insulinoma and gastrinoma, as we mentioned earlier. Non-functional, which means it does not secrete any relevant hormone, and it will be asymptomatic, and this is more commonly at the presentation. The other classifications depend on the pathological manifestation, actually. We have 3 grades. Grade 1 depends on the mitotic index and Ki-67 index. And if we ask what is the Ki-67 or mitotic index, those are reflecting the cell proliferation, the rapidity of the cell proliferation. So the higher, the more aggressiveness of the
Rahisa, we have interruption in the voice. Dr. Rahisa, are you there? Because your slide is stuck and there is no voice.
The technical issues here. Sorry for that. Can you hear me now?
Yes, Dr. Rahisa, we can hear you, and we can start from the same slide. Thank you.
Thank you. So as I mentioned, the other classification related to the pathological grading, grade 1, which considered well differentiated, low risk, and the grade 2 is intermediate risk, grade 3 is poorly differentiated. How we diagnose neuroendocrine tumor? As all tumor, we have tumor markers. The most common, which can be shared at any type of neuroendocrine tumor, and more specific, is chromogranin A. We have also other neuroendocrine tumor like chromogranin B, but the most specific is chromogranin A. Calcitonin for the medullary thyroid cancer will be specific. We have the 5-HIAA, which usually will be 24-hour urine collection for carcinoid syndrome, and also for other type of neuroendocrine tumor like gastrinoma, for example, we have gastrin level. For insulinoma, we have insulin level. Regarding the imaging, we can do CT scan and MRI to locate the tumor, but the most specific one is 68 gallium butyrate PET scan, which is somatostatin receptor imaging. And if you will ask why we should use this specific scan, because the neuroendocrine tumor cell, they have somatostatin receptor imaging.
somatostatin receptors on the cells. So that's why the gallium butyrate will be the most sensitive and specific scan to detect the tumor. Regarding histology and immunohistochemistry, usually the neuroendocrine tumor, they will be positive for chromogranin and synaptophysis. Treatment option, it differ actually. It depends on the location, grade, stage, and functionality of the tumor. Usually, the curative treatment is surgery if the tumor is localized and small. Other treatment option will be somatostatin analogs like octreotide or larinotide to control the hormone, reduce the growth of the tumor. Targeted therapy. Targeted therapy like everolimus and sunitinib in some cases. BRRT, which called peptide receptor radionuclide therapy. This is actually a radiation therapy delivered directly to the tumor or to the somatostatin receptor. And this is very specialized therapy. And I did see some successful cases with this type of therapy. Chemotherapy, this is for very aggressive, poorly differentiated type of cancer, which is usually will be dealt by the oncology team. Liver-directed therapy, this is for the liver metastasis, like if we want to reduce the symptoms or the tumor burden, we use embolization or ablation if we have single or double lesion in the liver. Observational therapy for slow growing tumor and asymptomatic tumor we just sometimes observe. Okay, it's just worth to mention about new medical therapy for MEN1 as we are talking about medullary thyroid cancer. This is a commentary paper that I did like maybe 2 years ago on a new treatment which can prevent genetic mutation in MEN1, but that was in rat. Actually, they discover leflunomide. This is a treatment which can, or it's an enzyme inhibitor which inhibit the enzyme conversion, and this will help to prevent a mutated cell to proliferate, and it can help to control the genetic mutation. Also, to mention also the other treatment option, this is a large study that we did during my fellowship regarding the appendicular tumor. And we're discussing here the treatment either hemicolectomy or tumor resection or appendicular tumor resection. And it showed that hemicolectomy will have better outcome than tumor resection. But it's really important to treat this tumor early to get a better result. Going back to medullary thyroid cancer, medullary thyroid cancer arises from parafollicular C cell in the thyroid, and it secretes calcitonin, as we know, and this is the tumor marker. It can be sporadic or hereditary, part of MEN2A or MEN2B symptoms. Associated with genetic mutation, ret proto-oncogene, management of medullary thyroid cancer is total thyroidectomy. Rodent data suggesting C cell stimulation. So this is the reason why the relation came only with medullary thyroid cancer, why the GLB was only connected to medullary thyroid cancer because of that. And this is raised the concern that some neuroendocrine tumor cell express GLB1 receptors, and certain GLB1 agonists have been shown to promote the growth of these cells in vitro. This suggests possible risk when using this medication in patients with NET expressing GLB1. And this is how is a GLB1 agonist works. It's created from the intestine, then it can stimulate the pancreas to increase GLP secretion. This will stimulate the pancreas to secrete insulin, and glucose will go into target tissue. That will reduce the blood glucose and control blood sugar. GLP-1 receptor agonists are a class of medication increasingly used recently in type 2 diabetes and obesity. And as we know, this agent improve glycemic control and promote weight gain, have demonstrated cardiovascular and renal benefit in large clinical trials. And as we know, the common agent we have exenatide, liraglutide, dulaglutide, semaglutide, and the most common is tergiveratide. And this is showed over the last few years, the licensed different GLP-1s, starting from the oral and injectable one. So, despite their therapeutic promise, concern have arisen regarding the association of the GLP-1s and medullary thyroid cancer, which is a rare one, which secretes calcitonin, as we mentioned. And the mechanism behind the concern, to go deeply in that, because of GLP-1 receptor are expressed in the rodent C cell, where GLP-1 agonist can lead to hyperplasia and neoplasia in the animal models. And the chronic GLP-1 receptor stimulation has been shown to increase calcitonin secretion in mice and to promote MTC formation. However, there is no human C cell express GLP-1 receptor at a very low level, raising the doubtful relevance of animal finding to human risk. So that was the concern behind that. So there is no strong evidence linked GLP-1 receptor and FDA boxed warning on GLP-1 receptor agonist for MTC or MN2. And if you buy any of the, or if you get any of the GLP-1 agonist medication, you will find a label on the in the leaflets of the medicine, which has a warning, and it's mentioned that the risk of thyroid C cell tumor is there in rodent. For example, this for semaglutide, it's mentioned that it's caused thyroid C cell tumor in rodent only. It is unknown where Ozempic caused thyroid C cell tumor, including medullary thyroid carcinoma in humans, as the human evidence for semaglutide induced rodent C cell in tumors has not been determined. So Ozempic is contraindicated in patient with personal or family history of MTC or in patient with multiple endocrine neoplasia syndrome type 2. And we need to counsel patient regarding the potential risk of MTC and symptoms of thyroid tumor. So it's clearly mentioned on the label. So what's the position of the FDA and EMA from GLP-1? Actually, they did put a box warning for liraglutide, semaglutide, dulaglutide, and tirzepatide. GLP-1 receptor agonists are contraindicated in patients with a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia type 2. This precaution is based on the rodent data, not confirmed human risk. And they did put a risk assessment. It depends on the type of the patient. If the general population, no risk factor, GLP-1 receptor agonist is considered safe. If there is a personal history of MTC or MEN2, it's contraindicated. If there is family history of MTC or MEN2, we should avoid use, consider alternative agent. In case of elevated baseline calcitonin, elevated before initiation, you may warrant endocrinology referral. But routine calcitonin monitoring is not recommended for all patients starting GLP-1 receptor agonist. And they conclude that the association between GLP-1 receptor agonist and medullary thyroid cancer in human remain unproven, with the majority of the current evidence reassuring. The FDA warning is precautionary based on the
Dr. Ahessa, we cannot hear you. Your voice is interrupted.
apologies for that. I'm back.
Welcome back, Dr. Ahessa.
So just to continue this study, actually, which has been published, they conduct a study from 2006 to 2018. They look at type 2 diabetes patients and on GLP-1s and second line anti-diabetic medication, which is DPP-4 inhibitor. They detected 2,562 cases of thyroid cancer. And actually, they conclude from this study that there is increased risk of thyroid cancer with GLP-1 receptor agonist. But to be honest, the most conflict was due to a lack of statistical power. They realized in this study that the risk increased with the patient who used the GLP-1 receptor agonist from 1 to 3 years. Another study, actually, if we go back to 2010, they did compare the patient who did start on GLP-1 with a control group, and it appeared to be that those responded in the C cell in rats and inactive in a human cell. And this was with liraglutide and exenatide and other GLP-1, as we can see from the graph. Another study in 2019, and this is observational study, cohort and nested case control, and those patients were on exenatide, and also they found incidence of thyroid cancer. But to be honest, there was no causational the evidence in these patients, and it's only observational study. Also here, another observational study in 2023, nested case control, around 2,256 cases with thyroid cancer and exposure with GLP-1 receptor agonist within with exenatide versus a match control group. And as we mentioned also, we can see that there is a medullary thyroid cancer incidence, but there is no direct cause or direct effect from GLP-1, as this is observational only. Another study, this is from 2023, a meta-analysis of 64 GLP-1 receptor agonist randomized control trial. 26 reported at least one thyroid cancer. And when they sub-analysis done in this study, they showed why it showed that there is also no direct cause of thyroid cancer in those patients. Here, another study, a meta-analysis of semaglutide with randomized control trial, and it showed also the incidence of thyroid cancer in semaglutide versus the control or the placebo group. And the thyroid cancer has not been infrequently reported in randomized control trials of GLP-1 receptor agonist in which cancer was not the primary outcome. Results suggest that thyroid cancer is a rare event which makes imprecise. No conclusive evidence of increased risk of thyroid cancer in GLP-1 receptor agonist users. And this one was the last study, which was published this year, the BRITO, which is a big study, which showed actually no clear evidence or direct link between GLP-1 receptor agonist and thyroid cancer. But they did found that the incidence of thyroid cancer are more with the patient who did use the GLP-1 agonists in less than 1 year. And when they did sub-analysis, they found that those patients, they are exposed to thyroid ultrasound more frequently than the older patient. That's why the incidence of thyroid cancer was higher in those patients. So the conclusion from this study, there is no causal relationship exist. Why do some observational studies suggest an increased risk of confounders, increased case detection only? Larger study needed power to assess the thyroid cancer with better standardization and ascertainment of thyroid cancer as an outcome. Robust analysis by thyroid cancer subtypes and more granular subgroups and sensitivity analysis to account for confounders and individual risk factors. Risk evaluation in more diverse population, younger individual, those obese, but so risk evaluation in more diverse population needed in younger patient, obese patient. So to be honest, all the studies and the latest one, the biggest one, it does not show any direct relation between GLP-1 agonist and thyroid cancer, and there is further studies needed to decide that. And this is actually a statement from the American Thyroid Association website. They did mention about this study that I just discussed in the previous slide, that no evidence that GLP-1 agonists associated with increased risk of thyroid cancer. This is all different study from this year, smaller study, which also showed no direct effect or statistically significant result of incidence of thyroid cancer with GLP-1 agonist. What about the other way around? Is there any protective effect of GLP-1 agonist with other type of cancer? So as you know, with weight loss and the effect of GLP-1 agonist, a lot of studies came up to see the effect on other type of cancer. As we know, a lot of causes of or a lot of type of cancer raised from obesity. And they found that there is actually good effect or a reduction in 13 type of obesity-related cancer in type 2 diabetes. Another study also showed that they might have modest reduced risk of 14 obesity-related cancer in diabetes patients, which is great. And finally, another one showed impact and safety of GLP-1 agonists, even with the breast cancer. And here also, this study just related to the gastrointestinal cancer, it showed also a non-significant association was observed with GLP-1 receptor agonist and the risk of gastrointestinal cancer. So I think it's all a promising result from those different studies. This is a specific also study to relate to semaglutide, and we can see here 5-year cancer risk reduced by 33% in GI cancer and female cancer and skin cancer. Here, drug specific related, there is reduction in the gastrointestinal cancer, breast cancer, and female cancer with dulaglutide, but there is increased risk with liraglutide by 70%. Uterine cancer, prostate cancer, and lymphoid cancer. So why do you think we have these different effects on multiple cancers? So it's really interesting when you dig more in GLP-1 receptor, you will find that GLP-1 can be found in a lot of tissues and organs in our body, as we can see in the brain, in the embryonic tumors, pancreas, thyroid, endocrine tumors, and gastrinoma, in the adrenal gland, adipose tissue, digestive tract, heart, lungs, and kidney. So safety issues and warning regarding GLP-1 receptor agonist, there is no clear evidence or strong evidence support the link between GLP-1 receptor agonist and thyroid cancer. A clinical implication for most patients of GLP-1 remains safe from oncological perspective. I will just conclude because I think there is no more time. But just a quick question, what you will do with your patient in the clinic? You need to discuss with the patient all the results, all the studies, and you need to let them to choose, especially if the patient has a history of papillary thyroid cancer, because this is the dilemma. If the patient has a history of papillary thyroid cancer and he's treated, what you will do? Will you start him on GLP-1 if he's diabetic or obese or not? For me, I do start my patient with explaining everything and with close monitoring. So for clinical practice, among the general population, benefit likely outweigh the possible risk of thyroid cancer, particularly small papillary thyroid cancer of indolent course. Among patients with family history of MTC or MEN2A2B should not be used. No evidence to support screening for thyroid nodules before initiating or during treatment with GLP-1 receptor agonist. No evidence to consider GLP-1 receptor agonist as an independent risk factor for thyroid cancer. And I think this was my last slide, just to take home message. Each physician should outweigh the risk and benefit and explain everything clearly to the patient, and the patient need to decide if you want to continue or not. And we need also to keep updated with all the studies regarding the risk of thyroid cancer in GLP-1 receptor agonist users. And by this, I will conclude my presentation. With this say, if you treat all your patients like they are your family, you will always do the right by the patient. Thank you.
Thank you, Dr. Hessa, for excellent presentation. It did answer a lot of questions. If there are still any queries, we can receive questions in Q&A box and we can discuss it at the end. Next, we will like to have a symposium but surveyor, and we would like to invite Dr. Ihab Al-Tayyib. Let us have his introduction with us. He's an endocrinology consultant in Prime Hospital. He has received his doctorate degree of endocrinology from Al-Azhar University, Egypt. He's holding a master's degree in obesity management from South Wales University, UK. He is editor-in-chief in the Journal of Advances in Obesity, Endocrinology, and Diabetes. He's founder of International Diabetes and Obesity Conference. We would like to welcome Dr. Ihab, and we would like to have a floor with you, Dr. Ihab. Welcome, Dr. Ihab.
Thanks, Dr. Ferial, for kind introduction. I would like to thank you personally and all colleagues for this fantastic presentation, Dr. Bdur, Dr. Hessa. Also, I would like to thank also Servier for holding this meeting. I am aware that my time is 15 minutes, so I will try to be on time. So the title chosen today is about dyslipidemia, and I really like the title chosen, Strike Early and Strike Strong. And just my disclosure. And really, it was, as we know, dyslipidemia, one of the chronic disease, as their companion, hypertension and diabetes mellitus. And this three chronic disease is widely prevalent globally and especially in our area in the Middle East.
Dr. Hab, would you please like to share your slides? We cannot see your
Not
slides.
shared?
Yeah. Thank you.
Sorry. I thought it is shared already. Is it now shared, doctor?
Yes, now we can see it. Thank you, Dr. Hab.
Thank you. Thank you. As I mentioned, dyslipidemia, the title chosen, Strike Early and Strike Strong. That's my disclosure. And as I mentioned, we have three chronic disease in our area here in the Middle East and then globally, dyslipidemia, diabetes mellitus, and hypertension. And they share many characteristics together with this disease. I will go for this soon. In Middle East, patient in the Middle East, it's surprisingly in this graph, which shows bar chart, which being cross-sectional epidemiological study in 4,378 outpatient, to see is any really risk factor in young patient. This patient, the mean age is 40, more or less, even younger. And for the surprise, the prevalence of cardiovascular risk factor, which is here mentioned 6 risk factor, as we know, dyslipidemia, abdominal obesity itself is a risk factor, hypertension, generalized obesity, diabetes, and smoking. And many of our patients have multiple cardiovascular risk factor in a younger age. So like dyslipidemia prevalence is 70%. So our population, 70% already dyslipidemic in the Middle East and the relatively young people. Similar like abdominal obesity 67, the second level hypertension obesity between 40 and 30 prevalence. The third level diabetes and smoking between 25 and 14.3. So there is what is the most highly prevalence of for cardiovascular risk factor. One word is dyslipidemia. So we are facing the risk of dyslipidemia in young population. And the same study by Al-Sheikh and his colleague in 2014, he can see that also patient in me, it's referred for the Middle East, that 60% of our young patients in this study have at least 3 cardiovascular risk factors. Like 18% of our patients have 1 risk factor, 20 have 2, 20 have 3. So if we submit all together, it will be 60% in young people also have cardiovascular risk factor. And as we saw before, dyslipidemia is the most prevalent one. If we go to focus in Gulf countries more, in this nice chart, we can see UAE, the prevalence range from 44 to 75 of dyslipidemia, while in Kuwait, very high, 85, Jordan, 80, Lebanon, 80, Qatar, 40, Bahrain, 24. The list here in Oman is 13.8. But what is the 3 major challenge in dyslipidemia in the Middle East? And I can refer this for globally also, low control rate. Very few of the patients achieve the target LDL. As we are know, as practicing doctors, physician, cardiologist, general practitioner, the main treatment or guideline directed toward LDL. Till this time, till this moment, the target of therapy is LDL, and is the one, the lower is the better. And of course, there is a close relation between LDL reduction and reduce the incidence of major cardiovascular events. So the target LDL, all guidelines toward LDL. So we have a very low control rate for controlling cholesterol, LDL still, and even patient go to doctor, prescribe medication, but there is low adherence. So we have low adherence or non-adherence, or what is the third problem is clinical inertia. Clinical inertia could be from the doctor, could be from the patient, like they don't intensify the treatment. Here another study by Fernandez and others about how high LDL increase the prevalence of atherosclerosis. I don't want to go too much to this sophisticated bar chart, but you can see that when LDL is more, there is more atherosclerosis, and there is more vascular site affection, coronary artery, plaque, carotid, iliofemoral, aorta. So there is a proportional relationship between increase LDL, you see here from 50 to 60, less atherosclerosis, and 60 to 70 start atherosclerosis 20%. And you can see with when we go higher for LDL, there is higher atherosclerosis and there is higher vascular site affection for plaque and atherosclerosis. And even for people which is their LDL could be appear normal for us, there is still subclinical atherosclerosis. So the lower is the better. You can see the level 50 to 60. This is like the level which really could be no evident clinically atherosclerosis. Of course, we all saw this graph before. How is cholesterol is the cause of atherosclerotic cardiovascular disease? The most predominant factor, causation to cause coronary vascular disease is dyslipidemia. All guidelines go toward LDL, intensify the treatment, strike early, strike strong, reduction, more and more reduction of LDL is better. Of course, in the top of lowering agent is a statin, and the statin. I know, of course, a lot of things about statin, but I can say just one word: statin, one of the most discovery in the history of medicine with insulin in the last century. So statin reduce cardiovascular cholesterol and cardiovascular disease. Of course, most of our patient, even high risk or very high risk or the new classification extreme risk, they don't achieve LDL. Because if you can see in my next slides, you can see there is risk stratification for our patient. When we see the patient in the clinic, we have to stratify our patient as low risk, moderate risk, high risk, very high risk, and extremely high risk. This is in the new guidelines in 2025 in European Society of Cardiology, the last meeting in Madrid. They make this classification, and when you classify your patient by his category of risk, you will understand which level of LDL you have to target because it is different. All right, here also very nice publication. It's been published in European Heart Journal in 2017, which shows that what the causation relationship between LDL and coronary heart disease, which is very evident. It is evident in the level of Mendelian randomization study. And Mendelian randomization study, it is about genetic epidemiological study, like to find genetic defect for familial hyperlipidemia, like LDL receptor defect or what. Many studies here, and which follow up for this was 52 years. And the population studied in all this randomization trial, Mendelian randomization trial, almost 200,000 patients. Also in the level of prospective cohort study, which many cohort study, one of them is Jupiter trial. I just no time to speak about, but Jupiter trial, which shows how LDL can protect from cardiovascular disease and reduce morbidity and mortality. And this median follow-up for 12 years, and the number of people involved in all this name of clinical cohort study, you can see in this, it is 400,000 patients. And lastly, randomized control trial, which is a smaller trial, and it was for 5 years, improve it, reduce it. Many trial here, you can see, improve it. So it is 1,960 patient also. What is the conclusion? The conclusion that every 1 millimole, or if we use milligram, every 38.7 milligram reduction in LDL, it will be translated to 22% reduction of cardiovascular disease in 5 years, as it's shown in randomized clinical trial, and it reduced cardiovascular disease by 32% in 12 years, as in shown in cohort studies, and reduced 52% as it's shown in Mendelian randomization studies. So the causation relation between LDL and coronary heart disease is evident without any doubts. And even this 1 millimole reduction in LDL, which is 38.7 milligram reduction, it is translated clinically to 23% reduction in major vascular event when we're using statin, because statin is a holy medication. It's not only about reduction of LDL, it also has anti-inflammatory pleiotropic effect. And you can see here many clinical trials. It's not only about only statin, but this like meta-analysis and systematic review of all medication, fibrate, like 9 trial, ezetimibe, 1 trial, niacin, 3 trial, diet, 4 trial, this CETP inhibitor, 3 trial, but still not FDA approved, bile acid sequestrant, 2 trials, statin, 25, ileal bypass, 1 trial also. And it was interesting. This is a surgery historically done in 90s and 80s for treatment of dyslipidemia. Before, of course, no need for this, but partial ileal bypass. No need for this now with the using of nice medication, PCSK9 inhibitor, 2 trial. All this trial together, large number of trial, it shows that it deserves reduction. Every 1 millimole in the LDL is associated with 23 reduction in cardiovascular disease. So the paradigm change now. Lower is better, earlier is better, larger is better, and reduction is better. So this is the philosophy. This is the theme of management of dyslipidemia now. I have to be more faster. The Swedish Heart Registry. I call my colleague just to read in detail about this. It is a large registry which including 40,600 patient with acute MI already, and then those patients being for secondary prevention. It deserves to reduce LDL, yes. Larger LDL, if you reduce more than 1.8 from 6 weeks after acute coronary event, compared with a smaller reduction, which is 0.3 millimole, there is much reduction of major cardiovascular effect when we reduce more LDL. So more reduction of cardiovascular disease. So this has been in Swedish Heart Registry. What was the guideline before? Because we have in 2019 and 2016, ESCC and EAS, usually every 3 years they make guidelines. In 2016, there is a guidelines, there is 2019, and there is one now in 2025. What was the guidelines that time? It says that if you don't reach LD goal, just reach to statin, maximize the dose of statin. If you don't reach, add other agent, and usually cholesterol absorption inhibitor, which is ezetimibe. And in 2019, they reinforce these guidelines. Guys, start with statin, maximize the dose, maximum tolerated. If not achieve the control LDL level, go to combine with ezetimibe. Either you go for single pill combination, like our molecule today, like single pill combination, like rosuvastatin with ezetimibe, or atorvastatin with ezetimibe, or even free combination. So in 2019 was this thing. And even another guidelines, AHA and ACC guidelines, they say categorize our patient. If your patient is very high risk, also start by high intensity to maximal statin. If not controlled, add ezetimibe. If not controlled, add PCSK9 inhibitor. And this is changed in 2021. If your patient is very high risk, don't waste time. Don't start by maximal dose of statin. No, go directly for single pill combination. This was the guidelines in 2019. And I will show the guidelines in 2025 to see the difference. In these guidelines, you classify your patient as low, moderate, high, and very high. And this also, there is a score system, online calculator. You can calculate to categorize your patient, to ask patient type 1 or type 2 duration of diabetes, the age, and the organ damage, familial. I mean, there is certain definition in every risk stratification to categorize your patient, special score being used, and it was only 4 categories: low, moderate, high, and very high. Low, your cutoff point target LDL 116 milligram, in moderate 100, in high 70, in very high 55 milligram. This in guidelines 2019. If you see guidelines 2016, you will find even this number is different. You will find this 70 only. But all after every guideline, there is a new clinical trial meta-analysis which shows more benefits, and this can be changed. And this is what happened, the change here. This is 2025 guidelines, which it's a bit different than the one 2019. I will put two change extreme risk. This is a new category, and the cutoff point 40. And this is extreme risk patient with already with atherosclerotic cardiovascular disease who have recurrent vascular event, and they are in a maximal dose of statin, or patient with polyvascular disease, coronary and peripheral artery disease. Those are extreme risk, and the target even lower to 40 milligram. So what is new? What is the difference between 2025 guidelines and 2019 guideline? The risk stratification is different. There is 5 risk stratification with different cut-off point of LDL, and there is another thing, the score itself is changed. The score in 2019 is called the score only, and it's a bit different. You'll find the number different, but in the new guidelines, it's called score 2 or score 2 OB for older population, also for people above 70. And the cutoff point is different, but it is more risk stratification and it's more clinically valid. Of course, no time to explain, but just this are two changes. The score system changes for risk stratification, and they added more extreme risk in the guidelines. So in October 2021, it was clear, the update in the guidelines, that combination of lipid lowering therapy as first line strategy in very high risk patients. So if your patient, very high risk patient, please go for single pill combination. Like, don't waste time for statin, maximize statin. No, go directly for single pill combination. This is a new EAS statement supporting upfront combination of high intensity statin ezetimibe in what's called fixed dose combination. Please, paradigm shift in dyslipidemia management from moving sequential treatment strategy to upfront use of combination. Sequential, statins and ezetimibe, no, go for single pill combination. Why? Because patients with atherosclerotic cardiovascular disease, particularly those with many risk factors or familial dyslipidemia, is unlikely LDL to be controlled with only maximum dose of high intensity statin. Therefore, this task force recommend for doctors, practitioner upfront combination of high intensity statin like rosuvastatin with ezetimibe and to be treatment for those patients, what's called fixed dose combination. Change in paradigm, treat to target, like where in this, what they want to say here, treat to target, like select the initial prescription likely to reach LDL target. Like if my patient is very high risk, so what is the target? Many patients, you can see them very high risk already with stent, with atherosclerotic cardiovascular disease. And when we're checking them in the clinic, their LDL is not reaching the target, which according to the guideline, less than 55. So if you see one of those patients and he already LDL more than 110, unlikely if you go for the maximal dose of high intensity statin to reduce to 55, because you know high intensity statin can reduce 50% from the basal LDL. So you may go here directly to single pill combination to reach the target directly. So despite individual variation, capacity of LDL reduction by statin monotherapy, it is predictable. And when we adding ezetimibe to the statin, either atorvastatin, flova, lova, para, sema, rosuvastatin, and beta, it is predictable. Almost, we got 15% more when we adding ezetimibe. So if you're using statin 50%, the high intensity, with ezetimibe 15, you can reach 65% reduction from the first treatment. And here in this, in 2025 also guidelines, what is the expected clinical benefit of LDL lowering therapy? You know, we have a lot of therapy. Let me go for high intensity statin and ezetimibe because this is our talk about today, 60 or 65. While, of course, if you go with PCSK9 inhibitor with this combination, you can get 80. If you add all this combination with bempedoic acid, which is a new oral non-statin therapy, you can reach to 86 reduction. So we can reach the 40 now. And because, of course, from guideline 2019 to guidelines 2025, there is a newer medication being in the market, pimpedoic acid, evenkumab, also for homozygous familial dyslipidemia, being FDA approved. So, like in our combination is rosuvastatin, ezetimibe together versus rosuvastatin alone. The combination provides superior efficacy to monotherapy of statin alone in reducing LDL with patients with already primary hypercholesterolemia. And we can see rosuvastatin 5% reduce 43. But if we adding ezetimibe, it becomes 56 in LDL. The 10 mg, 52. But if we adding ezetimibe 10 over 10, it will be 59. 20 rosuvastatin solos monotherapy is 54. But when we adding ezetimibe 10, is 63. So again, higher efficacy with 63 reduction in LDL when we're using combined therapy. So again, combination therapy, rosuvastatin, ezetimibe is more powerful than rosuvastatin monotherapy with more patient achieving LDL, and it is predictable reduction. And there's three clinical trial here, Kim et al., Yang et al., and Rosette. I will not go through it, but it's obvious. This is a combination and this is a bowl of monotherapy. You can see more reduction in LDL. And of course, it will be translated to reduction of MACE, or major adverse cardiovascular event. And not even this combination better in LDL only, which is the main target of the treatment. Like here with ezetimibe, more reduction 38 alone 23, but on all other parameter of lipid profile, non-HDL, total cholesterol, triglyceride, ApoB, high sensitive C-reactive protein also, and all are statistically significant. Adding ezetimibe to statin more effective than doubling statin dose, and this is for all statin. Like in rosuvastatin, when you're doubling, you got only 5% reduction, but when you're adding ezetimibe, you got 15 to 20 reduction, and this is also for atorvastatin and simvastatin. So, and you got less side effects. So adding ezetimibe to statin is more effective than doubling the statin dose. I need 5 minutes more. This is very nice trial. It's called Precise EVOS trial. EVOS like intravolemic ultrasound measurement. They measure the atheroma volume in coronary artery. It is in a small number of patients because like intervention study, it shows atheroma reduction when we're using statin alone or when we're using statin with ezetimibe. It's play rule or no. Here, the precise EVOS atorvastatin with ezetimibe, the reduction in atheroma volume by minus 1.2. While if I will lose atorvastatin alone is 0.7, and this is statistically significant. You can see the difference. Another trial is called Masuda trial, and in this Masuda trial also it is a smaller number of patients because also they measure intravolemic coronary artery plaque or atheroma. They measure it first in LDL level when you're using solo treatment like rosuvastatin alone, the reduction by 36%, while I am using rosuvastatin and ezetimibe, they are 55%. Okay, so powerful LDL lowering effect in combination, rosuvastatin and ezetimibe by 50% versus monotherapy, which is 36%, and the difference in between is statistically significant. And this translated to greater reduction in coronary plaque volume, which measured by ultrasound. It is 13.2 reduction when using ezetimibe with rosuvastatin versus only 3.1 reduction if I will use rosuvastatin alone. And you see here the baseline, here the lumen area is narrow, 6.3, and the plaque area is 8.6. After 6 or 9 months, lumen area become 7.9 bigger, and plaque area become less, 6.4. So we have LDL reduction less, and we have atheroma or coronary plaque reduction. All right. This is another also study by Kim and his colleagues published in Lancet in 2022, which shows that, which is called the racing trial. Is it wise to use a moderate intensity statin versus ezetimibe, not high intensity statin? Or I can use high intensity statin alone. So this was in 3,780 patients, high intensity, half of them, and moderate intensity with ezetimibe, half of this number. And they followed them for 3 years. The surprise is non-inferiority. Adding ezetimibe to moderate intensity statin is non-inferior to solo high intensity statin for cardiovascular event, non-inferior. But as numerical number for LDL, yes, even better. Less LDL reduction, it makes 72 versus by high intensity 58. And of course, discontinuation was more in high intensity, 80% here was 4.7 because 4% because we use higher dose. So this is the things now. Of course, and this is applicable for subgroup analysis, like for elderly over 75, yes, similar cardiovascular benefit in elderly and lower rate of side effect and discontinuation of the treatment. Even for people with percutaneous coronary intervention, similar cardiovascular benefit. For patients with diabetes, similar cardiovascular benefit. So it's similar cardiovascular benefit, but lower LDL as numerical number. Of course, adherence story. So this is the main power also of single pill combination. Significantly higher percentage of patients were adherent to single pill compared to free combination. 75% adherence, while 51 non-adherence. If I will use them as free combination, you can see when I use one tablet rosuvastatin with ezetimibe versus I use rosuvastatin and ezetimibe separate, compliance here or adherence 50% here, 75%, and the difference in between are statistically highly significant. I'm going for my last slide, and this is very important article published in last December only, and many of author names we can see here in UAE, and they making what's called improving therapeutic adherence and reducing therapeutic inertia in the management of people with cardiometabolic disease, a call for action to the Middle East. So they discuss two issues, what's called therapeutic adherence and therapeutic inertia. What is the what's this? This is group of experts. They meet what's called an evidence summit for cardiometabolic environment, which one in May 2024. And they study two phenomena, what's called therapeutic adherence and therapeutic inertia. Therapeutic adherence when people take the medicine regularly, and therapeutic non-adherence when the patient taking the medicine sometimes and stop sometimes. So what is the reason in our area in the Middle East for therapeutic non-adherence? And they also study therapeutic inertia. Therapeutic inertia, patient in the medicine, but doctor or the patient, they want to intensify the treatment, either for three common prevalent disease, metabolic disease, type 2 diabetes, hypertension, dyslipidemia. So all this applicable for these three diseases prevalent in the Middle East. The expert, they investigate and they try to find why there is, how to reduce the therapeutic non-adherence, how to reduce the therapeutic inertia. Therapeutic non-adherence, patient takes the medicine irregularly. How to reduce? They say, okay, multi-month prescription duration. Don't try the medicine for chronic disease 1 month, minimum 3 months. Maybe by here in UAE, we write 3 months for insurance purpose. Maybe in some other country, if the case is stable, can be reached to 6 months. Second thing, synchronized prescription. Write all medicine together, blood pressure, hypertension, dyslipidemia, aspirin, whatever in one prescription, what's called synchronized prescription, not to avoid missing things. Medication reconciliation by pharmacists. Pharmacists should look to the prescription to see if doubling medication or drug interaction medication, like maybe in rushing busy clinician, some medical error can happen. Also the use for e-health and m-health. And thanks for COVID, called all drama, but it makes the world toward e-health or telehealth. Like for chronic disease, you can make interview with your doctor in telehealth, or and m-health. M-health, mobile health also. Mobile health for wearable devices like CGM, diabetes management, and ambulatory blood pressure monitoring, all wearable devices. It's called like a digital platform. So if we trying to do all these things, we will reduce therapeutic non-adherence of the patient. How to minimize therapeutic inertia? How to push either doctor or patient to go aggressively treatment of the disease. Don't be dyslipidemia, LDL high, and just keep statin. Not, you don't want to go further. So mind shift toward aggressive cardiovascular risk factor, diabetes, hypertension, dyslipidemia. Make guidelines simple for doctor, simple page guidelines like this, like this. Because we see if we go detailed guidelines like a book, no time. Also, behavioral nudge pushing strategy, like you're knocking someone by your elbow for doctor and the patient, and the intensifying strategy as well. So this will minimize therapeutic energy. There is some other factor can help in both reducing therapeutic non-adherence and therapeutic inertia. Single pill combination. In diabetes management, we have metformin with oral DPP4, metformin with SGLT2 inhibitor now. In hypertension, ACE ARBs with calcium channel blocker, and also in dyslipidemia now, statin with ezetimibe. Medication and home monitoring devices, structured patient education for the patient, continuous medical education for the doctor, team-based care, home monitoring, and continuity
Dr.
of care.
Ahab,
Yes.
Dr. Ahab, sorry to interrupt you. Can we just conclude? We are
Yeah.
exceeding the time,
No,
please.
no, this last slide I reached.
Sure, thank you.
Take home message. Despite individual variation, the capacity of LDL cholesterol reduction by statin monotherapy and lipid lowering combination is predictable. Treat to target, select initial prescription which reach LDL. If you need more than 50, go for single pill combination. The combination statin and ezetimibe is more powerful than rosuvastatin monotherapy to reach LDL goal, which been translated to reduction of cardiovascular risk. And even clinical guidelines now recommend combination of statin and ezetimibe if LDL goal are not achieved with the maximum tolerated statin. Thank you.
Thank you, Dr. Ahab. Thank you so much. Here we conclude the presentations. I would highly appreciate all the expert presenters for sharing their expertise and excellent sessions by Dr. Anada, Dr. Ahessa, Dr. Abudur, and Dr. Ehab. We have limited time for question answer session. I would like panelists to be on board to answer a few questions as the time allows. First question for Dr. Anada. Dr. Ananda, you have beautifully explained the update between 2015 and 2025 guidelines. Is there any direct correlation between the cutoffs for FNA, keeping in view of direct classification, and ATA 2025?
That's a good question. So usually, as we notice it in the new guideline, the updated ATA recommendation focused less on the size alone and more on ultrasound risk patterns. So that's the big move from the when we are doing and changing from the also American culture cardiology. So I think that's more allowing for decision making by patient and the physician. So, for example, we saw like high suspicious nodule, especially those who are solid, hypoechoic, or usually marked hypoechoic. With some worrisome features like panictates or taller, more than wide. So usually we tend to biopsy them with a smaller cut size. So this is the major change, which we are really maybe those days we needed. So it's more relies on ultrasound feature itself. And
Does it
so
mean that lowering the threshold for FNA will result in more FNAs as compared to the previous policies? Or is there any other thing we take into consideration other than ultrasound features?
yeah. That's usually good questions because when we tend to biopsy, maybe we do ATA. We do when we don't want to biopsy, maybe we will more do the ACR. So allow you to go in between guidelines and how you think you approach this patient better. But I think this is take you more to understand the nodule itself and what's the worrisome features is in there rather than to go on size. I think it's more reliable, more accurate to go for the pattern rather than the size. So that's why I think ATM give you more, again, go towards seeing the ultrasound yourself rather than rely on the only size. So
So
yes,
it gives us a clearer and better picture in terms of ultrasound features to decide on FNA.
yes,
Thank you, Dr. Ananda. Thank you so much. Next question is for Dr. Abudur. Dr. Abudur, is there any indication to treat subclinical hyperthyroidism in the cases with amidron-induced thyrotoxicosis?
Yeah, that's a very practical question. So when it comes to about treating subclinical disease, first we have to see whether we are dealing with type 1 or type 2, because type 2 is self-limited disease. It would go with time, and it's a mild form, but should be taken into account whether to treat or not the severity of underlying heart disease. Subtle disease, probably no need, it will go with time, but if there's severe and you see how much patients affected by that. But if you're speaking about type 1, there is always an autonomy thyroid. So leaving this untreated for the long term, there's no general or unified answer for this, but leaving it for the very long term, it seems to me unhealthy for the heart.
Agreed. Thank you so much, Dr. Abudur. There is one more question for you. How frequent is amidron-induced hypothyroidism reversible after discontinuing amidron therapy?
Okay, that's a very practical question, very nice one. In amiodarone-induced hypothyroidism, when there is an absence of the autoimmune Hashimoto thyroid antibodies, there is 50% chance that the gland will go back to normal once the iodine load goes out from the thyroid gland. That's why if the cardiologist decided to discontinue amiodarone and patient was on thyroxine, the TFT profile should be checked in the next coming between 2 to 3 months to check to see if the thyroxine can be discontinued as well.
Is there any specific target TSH we are looking for the treatment in amidron-induced hypothyroidism?
Okay, that's a very relevant question, because when you are asking about the target for TSH in amidron-induced hypothyroidism, you're speaking about a subset of patients that are very likely to be elderly and already have a diseased heart. So they're having very severe hypothyroid, then probably you don't want to push the TSH suddenly down. You might put it between the upper limit, like up to 10, like a subclinical form. Or otherwise, if it was like mild or moderate, you can push it to normal TSH, but toward the last third range of the upper limit.
Excellent. Thank you so much, Dr. Abudur. We have one question for Dr. Ahessa. Patients who are already diagnosed case of papillary thyroid cancer, you mentioned that we have to do risk evaluation of them before starting GLP-1 agonists. So kindly, can you shed light on that? What type of risk evaluation do usually we need?
Actually, this is really important question. For papillary thyroid cancer, as we know, this is the most common type of thyroid cancer with excellent prognosis, actually. So the risk assessment, we call it a dynamic risk assessment. So with each visit, clinic visit or follow-up, we need to assess the patient to decide the risk. And whenever the patient had a good follow-up, like a longer follow-up without any recurrence, has excellent prognosis. So if the patient, usually we follow up biochemically by tumor marker, which is thyroglobulin for the papillary thyroid cancer, and actually, which is usually we do it between 3 to 6 months. If it is undetectable with suppressed TSH level according to the risk of the patient, we decide at what level. And with thyroid ultrasound, which is usually done yearly if the patient is stable and there is no elevation in the thyroglobulin or no any finding in the thyroid ultrasound, usually the patient will be low risk. We assess them at the low risk, and usually we can start him with GLP-1 agonist. And at the end, we discuss with the patient that all the evidence, all the studies which we have currently regarding GLP-1, and we need to explain to him clearly so he can decide if he wants to go for it or not. Otherwise, after we starting it, if we decide that we will start a GLP-1 and BTC patient, we will monitor him every 3 months with thyroglobulin and ultrasound as needed, depend on the thyroglobulin results.
Excellent, excellent, Dr. Hessa. There is one more question for you from our audience. Is it necessary to do an ultrasound neck or abdominal ultrasound to look for gallstones or any underlying neuroendocrine tumor before starting GLP-1 agonists?
That's very common question and very common practice because I get a lot of patients they came actually with incidental thyroid nodule because they decide to start GLP-1 and they did ultrasound thyroid and they found that they have nodule. But according to the guidelines, there's no really recommendation to do thyroid ultrasound or abdomen ultrasound before starting GLP-1 agonist. So my practice is not to do any scan before starting it.
Great, Dr. Hassa. There is one question from my side. As we are following the new practice of active surveillance for the patients who are having papillary microcarcinomas, less than usually 1 centimeter. And most of the time, as we know, the prevalence of obesity is very high. So patients who are undergoing active surveillance for PTCs, how we are going to explain them the addition of GLP-1 agonists to their therapy? Like here, we are not talking about dynamic risk stratification. Patient is doing active surveillance. So what are the risks we need to explain and how to convince them in this context?
Actually, for those patients, you know that micropapillary cancer, they are considered very low risk. Yeah, and it's very, but very, very rare cases we had actually, they presented with aggressive pathology. So we can have aggressive pathology with micropapillary cancer. For those patients, usually I would be also cautious with them and I will monitor them closely. But regarding GLP-1, it will be the same for myself. I do explain everything, and if the patient is happy to start a medication, I will start with GLP-1 with regular follow-up.
Okay, great. Thank you so much, Dr. Ahesa. There is one question for Dr. Ehab. Can triple therapy started directly to treat dyslipidemia in patients with sky-high LDL as primary or secondary prevention? I assume by triple therapy, they mean the combination of statin, ezetimibe, and PCSK9 inhibitor. So can you please help us in that?
Nice question. Actually, there is in 2021, October 21, they speak about that. In patient, as I mentioned, in very high risk factor, you can go for single pill combination directly. If not reach the target, go for PCSK9 inhibitor. But for those people with extremely, like they already have atherosclerotic cardiovascular disease and other vascular event, which is now in the new guidelines extremely high risk, yeah, you may go for the triple therapy. So with this category, because unlikely you can reach LDL 40 milligram, so you can go for ezetimibe with statin maximum dose, high intensity with PCSK9 inhibitor, like directly in this category, and also in my idea in very high LDL, if you think that ezetimibe and the statin, which is reduced 65, will not reach the target according to the risk factor of the patient, you may guide to combine with. We have many medication now. There's a newer oral one. This is available now in some countries, will be here soon. And you use the pimpidoic acid. So you can use the 3 pimpidoic acid with ezetimibe and the statin together. But specific for your question, in very extremely high risk, you can go for triple therapy directly.
Thank you, Dr. Ihab. Thank you. Thank you for the audience for being patient and attending this long session. I know we are lagging by the time. I'm sorry if we couldn't answer a few questions. And thank you for the presenters. Extremely appreciated and honored to all have you all on board. The CME for this particular session will be available after 4 weeks. You will be receiving an evaluation or survey form. Please fill out the form to receive your CME credits. The whole lecture will be available on our YouTube session, EDS Institute website as well. There are a few exciting opportunities and learning opportunities we are going to have in future. The most recent one is going to happen tomorrow. It's in collaboration with Sharjah University and Emirates Diabetes and Endocrine Society. Basically, the focus of this CREATE program is to turn clinical challenges into research opportunities. It's going to be an excellent platform to come up with the interesting cases or the case series to indulge into the research activities so we can have a pool data from our own population. It's going to held tomorrow, 25th of September. Next activity is going to be even more exciting. This is a collaboration between EDES and American Diabetes Association, focusing on the diabetes technology work. It's an excellent course based on the real case-based scenarios and to help immensely in the clinical practice to control and have optimum glycemic control in different categories of patients that we deal in usual clinics. So I highly recommend to attend with this program, which is accredited by 3.5 CME hours. Not stopping here, we are going to have an excellent continuation of the EDEC. We are going to have our conference in 2026, dated 6th to 8th of February. Hoping to see you all to attend this excellent academic opportunity to further accelerate in your career. Nonetheless, followed by that, we are going to have at the conference endocrine ultrasound course. You can access and register for all these activities on Emirates Diabetes Endocrine Society website, and we can connect to us through MCI Middle East. Below are the contact numbers. You can follow us on Facebook, Instagram, LinkedIn, and Twitter with the following details. I hope today's session was helpful for all candidates. We have a huge number of attendees. Thank you to all for being on board with us and keep helping us in continuing this process of education and training for all of us. Thank you all. Thank you, speakers, again. Thank you. We are honored to have you on board. Dr. Abudur, Dr. Hessa, Dr. Anada, and Dr. Ahab, extremely appreciated for your attendance today.
Thanks.